to minimize this treatment and to reduce post-operative complications, so that we may have to reassess what the contraindications are to single visit therapy. When we look at the literature, and this is one of the oldest controversies or controversies in endodontics today. Do you do it in one visit? Is it better to do it in multiple visits? A lot has been written about it. Very many endodontists have been very passionate one way or the other. And you can find support for single visit and support for multi-visit treatment in the literature without any problem. But just to summarize what I found, and I'm going back to a paper written by Ashkenaz in 1984, and he stressed that a high level of endodontic competence is required for single visit endodontics. And we're going to come back to this because this is very important. Generally, the impression is that there's a higher risk of flare-up with single visit endodontics. Patients are more likely to experience pain in the first week and require analgesics with single visit. There doesn't seem to be any difference in between single and multi-visit for long-term complications and periapical healing. And my good friend Martin Trope, who will be one of the speakers in the next series with Hugo, his paper has changed the way endodontics has been practiced for many years. Based on his study, he showed that there was a 10% increase in healing rate for multi-visit when calcium hydroxide was used as an intracanal medication, compared to single visit where no intracanal, obviously, medication was used. But this, to me, is very important. Ashkenaz said that a high level of endodontic competence is required. And in his paper, I'm going to quote him, he said the clinician should clinically evaluate every aspect of his or her endodontic practice by determining the incidences of biomechanical errors, such as ledging, perforations, over-instrumentation, broken instruments, flare-ups, and failures. And once a high level of competence is attained, one-visit endodontics can be successfully performed if well-skilled clinicians choose their cases carefully and adhere to basic endodontic principles. I'm not going to go over the indications for single visit, but I want to go over some of the typical contraindications for single visit that I saw in the literature. So these are situations where single visit is not recommended: painful necrotic tooth with no sinus tract, severe anatomical anomalies or procedure difficulties like calcifications, dilacerations, asymptomatic non-vital molars with periapical pathosis and no sinus tract, symptomatic apical periodontitis with severe pain on percussion, most retreatment cases, patients with TMJ dysfunction who can't keep their mouth open for long periods of time, and acute alveolar abscess with persistent drainage that you cannot control or stop. You cannot stop the drainage on that first visit. So